We are continuing with the Lumen Global Chats at the conclusion of day one at the 19th Lumen Global Meeting in Jaipur, India. And joining me is Dr. Christopher Granger from Duke University. Christopher, absolute pleasure having you join us here.
As it is mine.
What did you think of day one?
It was incredible, Samir, and I think it's a real testament to the timing of what you've been doing and what frankly, we're delighted to be helping you to do, is to take what a group of people who's passionate that we can save lives by doing something very simple, that is identifying patients who are having ST segment elevation MI and rapidly getting them the best reperfusion therapy. We can save a huge number of lives. And we've been doing this now for about 15 years, since the 2003 DYNAMI study, the Cindy Grinds showing in her overview that primary PCI is clearly the best treatment, and the early experiences that we had in the United States trying to organize and coordinate emergency medical care, emergency medical services, primary PCI, different networks of hospitals. And we've shown that we can make a real difference. And now what's happening that I'm so excited about is we've got this part of the world where really the burden of coronary disease exists, much more than anywhere else in the world. If you want to make an impact on human beings' lives who have heart disease, you have to be involved in India and Asia.
So we should feel reasonably happy about what we have accomplished together in the last decade?
So I'm delighted. I'm really exhilarated about what's happening. But having said that, there's a lot more to do.
Absolutely.
And I think where we are now, my sense is we're near the tipping point. That what's happened is there are groups of people in India and in Asia who have now shown it can be done. Lives can be saved in a major way.
Chris, you have pioneered the movement since almost a decade and a half, maybe longer. What does this mean to you coming to Asia and to India?
Well, so for me it's incredibly gratifying because, this is in fact part of, I come from the Duke Clinical Research Institute. Our mission statement says we're doing research to improve the care of patients around the world. Because one of the great things about medicine, about medical research, about medical care, is it does bring us together. And in a world where sometimes we're being pulled apart and too balkanized now, it's terrific to have medicine to kind of bring people together and say, we can make a difference for human beings around the world.
It really is most humbling and also very inspiring when you sit in this session and you watch. It seemed just like the other day, when we talked about a door to balloon time, these guys said, oh, what's that? And now the same people are having outcome measures, they're talking about quality initiatives, they're talking about ways to improve their insurance. It really must be very gratifying.
Well, those are some of the key things, right? That's remarkable. And we know, and you led up that terrific manuscript that outlined what are the key 6 or 7 barriers to providing STEMI reperfusion care that will save lives in India, and
I think it's also relevant to the rest of the region.
I think it's relevant to it's relevant to all low and middle income countries, and a couple of the key ones which we see now are changing are emergency medical services becoming organized, are insurance issues becoming overcome, much better insurance being provided across the region, and a variety of other issues, including, Samir, and this is something where you've been really helpful, because we have to enable passionate people. We have to identify, and there are plenty of passionate people out there who want to make the world a better place and help save lives. But they need to be enabled. They need to see, this is something I can do with my life that will make a huge difference to other people. And you've been able to do that, and we've got a lot of them at this meeting.
Now, one of the very unique challenges which has emerged, and I did not discuss that during day one. Hopefully, tomorrow will be a renewed opportunity, is that traditionally a lot of these STEMI networks, a lot of improvement in the methodology occurs with the support of industry. In India, we've had a stent pricing issue which has brought the price of US FDA approved drug eluting stents to, as an example, from almost $1,200 to $300 to $400, taking away the incentive from the industry to help promote systems. Now, you're very familiar with the Latin work I'm doing in South America, and we've recently taken care of, we've just crossed 500,000 patients. None of that work was possible without the financial support of the Medtronic Foundation. They are also able to do that because there is still some profitability in their products, whereas in this region, particularly in India, suddenly when you see the price coming to a fraction of what you were selling before, it becomes very hard.
And it's a double-edged sword, isn't it? I mean, in some ways it is really good to have those prices down low enough so that there's less of a financial barrier. But you're right,
it takes away the innovation.
It's nice to have an incentive for industry to partner with us when they have good products, to be able to partner with us to promote the application of life-saving care.
So we watched presentation from 5 countries today. To start with, they were Indonesia, Philippines, Thailand, Malaysia, and Bangladesh. What struck you as the most progressive, or are they almost pursuing the right strategy?
You made this point. I mean, Singapore is the most progressive, right? And Singapore is probably more advanced than the United States because it's a highly organized country that's small, that's got really talented people and information systems and enough resources to do that. So it's remarkable. They're kind of the lighthouse in Asia, aren't they? In terms
Absolutely,
of this type
I
of
think
work.
they are.
But then the other countries that you mentioned, I mean, I'm amazed at, like, we were and maybe I think it does in part have to do with the meeting that in Malaysia when we met with the Minister of Health.
Absolutely.
At one of the Lumen global meetings 2 years
2015,
ago.
16, sorry.
And it's remarkable to see what's happened there. I mean, they've really pulled together. They've got a common data source and structure, and their PCI centers are really stepping up to the plate and implementing proven effective reperfusion.
So let's take a step back here. When I started Lumen Global, taking it out of Miami and bringing it over to different parts of the world, including Asia, one of the intents was, let this be bidirectional. We are not only here to teach you some of the lessons which we have learned, but also learn from you. Have you learned something?
Absolutely. And I mean, you know that in the United States, I think one of our biggest challenges is sometimes we get complacent, and we're too oriented towards all the money and the ingrained health systems that are competing with each other, and you come here but I think we've done a pretty good job in the United States in spite of that. But you come here and it gives you a renewed sense of purpose in the United States to continue doing what we're doing. And we've got a long way to go in the United States before we're optimized. I mean, I think we have some good systems in place. We've got lots of regions that are doing well, but we could still be doing a lot better.
So as we examined and objectively reviewed the presentations from 5 countries today, another 5 tomorrow, plus of course we throw in Singapore, And the nations tomorrow are going to be India, Myanmar, Cambodia, Mauritius and Nepal. And they've been requesting the Lumen Foundation to come and help them somewhat. And of course, I'll put Sasko Kadev there, with his Mount Everest. He's so passionate about Nepal. But as we go back there, and if you were writing a white paper to give them 3 best advices how to further improve your situation, what would those be?
Well, I mean, and I would refer to some of what you've been writing about now. I think the first step is to make sure that the PCI centers are doing a good job, that they're delivering primary PCI, because the easiest thing to do is to have patients who present to a PCI center to get world-class care. Every PCI center in the world can do that fairly easily.
Okay.
So that means 24/7 measuring not only door to balloon for those patients, but first medical contact to balloon for those who are transferred or those who are brought in by EMS, which isn't so many, but nonetheless, that begins the engagement of EMS.
So here is the specific challenge because I have my ears on the ground in this part of the world, I can tell you the real situation. There are primary PCI centers which still give thrombolysis, which I think is virtually it's criminal, really. It's a practice which should be abhorred with the strongest term. That's number one. Number two, India is trying to present itself as the most fertile territory for pharmacoinvasive management, whereas the patients are presenting at 6 hours, which virtually takes away the benefits of thrombolytic therapy.
So this is another one of the three priorities, I think, and it's not easy, but it's so important that if it's taking patients 4 to 6 hours to present after symptom onset, unlike this has been totally transformed in the United States.
Right.
So when a person calls 911 now in the United States with chest pain, and it turns out that it's a STEMI, it's less than 50 minutes from symptom onset until the paramedics arrive at their side.
Fantastic.
And that gives us enormous opportunity. Then if you're only an hour until PCI is performed, then you can, a lot of these patients, we can abort their MI or have minimal myocardial damage, prevent cardiogenic shock, prevent cardiac arrest. It's so important.
All of the above. So how do you reach that situation now? Is it the press and the media? Is it directly trying to reach the patient? How do you make this change?
So we don't know how to do it. But what we do know is that it did happen. It used to be 2 hours in the United States, and now it's less than 50 minutes. And Samir, I think part of that was this work that we're doing here.
Right.
Part of it is establishing regional networks for STEMI care and getting the word out, and they should be promoted in local news and national news. They should be promoted by national cardiology societies and medical societies. And then the word gets out. But I think there also does need to be a deliberate public education campaign.
Should you keep the politicians out of it?
No. I think we need to have the politicians absolutely engaged.
So it's as we talk about it in the United States all the time, it has to be a broad but valuable group of stakeholders, no?
Yeah. Then the third thing that we saw today, a third thing, there's a dozen things that need to be done, but these are some of the most important, is to have a common data structure so that people are measuring what they're doing and compare it to the other people in their region and in their country. And again, we've seen that. It can be pretty simple. Ivan Rokos, who's here, has been really now become one of the world's best advocates for a simple set of variables that allows us to capture the essence of the course of our patients who have ST segment elevation MI and how they're treated. And if we do that and we see how are they doing in the various PCI centers in Rajasthan, as is happening right now, thanks to last year's efforts, then we can, then each PCI center will see, am I doing well or not compared to my peers? If I am, terrific, keep doing it, do it even better. If I'm not, What are the best practices that I can learn from these other centers?
Educate me more, Chris, about giving further direction to Lumen Global and Lumen Foundation in addressing a most pressing need, qualitative and quantitative improvement of the ambulance system. This is, if you take a look at it, India may be a poor country, but Indians are not necessarily poor. There is a lot of wealth here. In fact, the latest Forbes magazine listed India as having the third highest number of billionaires. How do we now go ahead and this should not be, there are two brothers here, the Ambani brothers, whose combined wealth is 60, 80 billion dollars, maybe more. There has to be a way, somebody needs to come and make a big difference, both in the quantity. I've always had a feeling, you improve two aspects, insurance and ambulance, India will be totally different.
I think you're right. Insurance, ambulance, and data and systematic data collection. And you made this point, Samir, which I think is critically important, and that is in the United States in 2008, less than half, even in our best systems, less than half of ambulances had EKG equipment and
Right.
did pre-hospital EKGs.
Right.
And now it's 90%. So it wasn't so long ago that in the United States we had EMS services that weren't able to support best practices in STEMI care. And I think for people in India, and the other thing which we talked about today, which I think is very true, is like India is not one place. And there are some great examples that we heard about today.
Mm-hmm.
Some regions of India, including Rajasthan, including Tamil Nadu, including Kerala.
Right.
There's some areas in India that are actually doing
Pockets
remarkable
of
work.
excellence.
Pockets of excellence, and they're engaging EMS and getting their emergency medical services up to speed. And I think when people see that and realize how did they do it, and then advocate to their local governments to invest in emergency medical services, it's really critically important for this part of healthcare.
I was even thinking, and let me know if I'm being wildly optimistic, which sometimes I can be, but if you don't dream, then you'll never do it. In a single stroke yesterday, in the nation's annual budget, of course, the motivation is political because there is an election coming up in 1 year, but the national government has now come up with the policy to provide coverage to almost 50 million people. And I'm even wondering whether we should, on behalf of the Lumen Foundation, write a letter to the Indian Prime Minister saying that, look, here is one aspect where you can fundamentally change the epidemiology and demographics in India by impacting on heart attacks, by infusing more capital for ambulances.
I really like it. And now, I think now we're getting almost a tradition of this, of each year publishing something that's aligned with the Lumen organization that kind of promotes an aspect of what's happening that we think is especially important. And I think now would be perfect timing to make just those points, that insurance, that EMS, that data collection and feedback, and we're still at the point of demonstration projects. And this is where we were, again, back in the United States in about 2005 to 2007 is when all this work was going on. Tim Henry, Ivan Rokos, us in North Carolina, Alice Jacobs in Boston, and others were doing these demonstration projects. And once there were enough of those, then everybody said, we all have to do this. We can do it, and we've had people that have showed us a template for how to do it, and now we all need to do it.
I want to, Chris, use this forum and my conversations with a man I enormously respect. Look, I've learned so much from you, and I've been fortunate enough to disseminate it to the rest of the world with a partnership with you and so many others. Now, let's try to make further inroads into some things which are happening in India. Why are they struggling, you think, so much in getting stakeholders on board? Because
Well,
if you take a look at it, one of the issues they are having is that look, I understand the aspect of hyper competitive.
Yeah.
We also know there is a tremendous maldistribution of cath labs. You know, there is a cath lab next door which wants to do a STEMI because it's a profitable procedure. And then there are vast expanses of the country with nothing available.
Yeah. Well, in competition, I'm glad you brought that up, because consistently, competition between PCI centers was called the single most important barrier to the work that we did in the early days. People said, you just can't get PCI centers to work together because their livelihood is at stake and they don't want to share their practices and jeopardize their competitive edge. And what happened was we got their leaders together, their cardiologists, on behalf of their patients. And people said, this is totally inappropriate. We're all going to do better. And you know who's going to do really better is our patients,
right,
if we work together. And it's going to make us all more competitive.
Okay, so you want to benefit the patient, but because of the hyper competitive atmosphere, the physicians are not coming together. How do you change that?
Well, I think the way you change it is like today and tomorrow. It's like bringing people together, identifying, you know, kind of some of the people who have been successful at overcoming some of the barriers to be fully engaged and passionate about what they do, to show that it can be done, to show that it makes a huge difference. And then India is full of people who are compassionate people who want to make India better.
Absolutely, and some very, very bright and very talented and skilled cardiologists. Now, take me further into this, and I truly, on this particular aspect, I want to get to the bottom of it. How do you get more media and press involved?
Well, I can tell you what we did in the work in North Carolina is we engaged the professional societies, American Heart Association, American College of Cardiology for us. We went to the state emergency medical services group and the state legislature and the press, and this is a place where competition is good, because each of these centers found it to be gratifying if they could, because they were doing good work, they were investing in it, and when they went to the local press and said, you know, gave examples of patients whose lives were saved as a result of this investment, that was very powerful and really helped to reinforce, including in the public's eye, because as you know, as we've been saying, there may be no single thing in India, or at least it's going to be impossible to make the strides that are necessary without the population calling faster and coming in faster with symptoms of MI.
Let's talk about the general physicians, the general practitioners, the GP as they call them. So about 5 years ago, after this fact struck me with the massive thrust, I realized that I think it's true all over, but more in India. I think in the United States, we've been trained, you get chest pain, you call 911. In India, you get chest pain, you call your GP.
Yeah, yeah.
So we realized that, and we started this program empowering the general physician, correct?
Absolutely. It's another critical piece. You know, it's a great example, Samir, because you know I think we know what needs to happen and what the principles are of how we can deliver the best care for STEMI. But every area, every country, maybe even every hospital has its own set of specific barriers that need to be identified and addressed, and strategies to overcome those. And that's a key one in India is how do we get the GP
involved in the process. Last question for you. Give me your 3 best recommendations for improving STEMI care in India.
So again, I'll just reiterate. I think we must have advancement of EMS services. That we can't get to a place where kind of the full capacity of STEMI networks is leveraged without better EMS services. We must have patients insured adequately so that there's not this financial barrier, and we must have data that's collected in a systematic way. That will help. Let me link that back to the patient. That will also help to make sure that the results of the data are publicized so that the public knows that STEMI care is improved, but they're a partner in it, and they have to make sure to call when their loved one, their family member, their patients, if they're GPs themselves, get symptoms of myocardial infarction.
So good at answering that, I'm going to ask you one more question. Telemedicine, how do you see its relevance in India?
So telemedicine, and I'll even say more broadly, information technology, because information technology is one of the great strengths of India.
Absolutely.
So much of the world activity is happening in India. So how can information technology be leveraged? Telemedicine is one example. I mean, the critical, it's simple. When a person has symptoms of a myocardial infarction, the earlier an EKG can be obtained, and that information can be interpreted, and then once STEMI is diagnosed, that there can be a system where that patient gets to the appropriate hospital. Those are the key things. And telemedicine and information technology can certainly play a major role in getting the EKG sent to a place that can interpret it, and then that information linked back to get the patient to the appropriate hospital.
So you're familiar with the Rahat system I created?
Yes.
Why do you think it has had a slow uptake?
Well, I think it's a combination. Again, it needs demonstration that it's working, and I think that's happening. And there is some investment in it, and then it needs to fit in with other things that people are doing.
And get in the press involved, I think, is
and get the press involved. But it's kind of, again, it's like this, it's like this tipping point. Once one gets to a certain point, then all of a sudden people say, Eureka, we have a solution, and then it can really catch on.
Just amazing. It's a pleasure having you at Lumen Global. We'll interact more tomorrow.
So great to be here, Samir. Thank you very much.
Thank you.